There are really very few things in life as profoundly emotional, or honestly, as deeply human as the yearning to start a family. It's a fundamental drive. But when that journey doesn't just happen naturally, it can quickly turn into one of the absolute most stressful, anxiety-inducing periods of a person's entire life. Welcome to this explainer. Today we're unpacking a really critical, highly sensitive issue right at the intersection of public policy, medical ethics, and deeply personal family planning. We are taking a hard look at the push to expand fertility funding and why well-intentioned financial support absolutely must be paired with strict medical safeguards. Okay, let's dive into this.
Here's our roadmap for today. We're going to start by checking out Singapore's new push for fertility support. From there, we'll dive into the emotional vulnerabilities of patients and how the industry sometimes sells this illusion of certainty. Then, we look at the hard medical evidence, peering into the future at the next ethical frontier. And finally, we'll talk about concrete policy solutions to safeguard public funds.
Section 1. Singapore's new fertility push.
Let's start by looking at the big picture. Because to really understand why this conversation is so incredibly urgent right now, we have to look at the macro problem. Why is the government actively looking to expand fertility health support and IVF funding in the first place? Well, 0.87. 0.87. That is Singapore's resident total fertility rate in 2025, which has fallen to just a staggering record low. To put that into perspective, citizen births dropped by 10.8% to just about 26,100. So, this demographic reality, it completely sets the stakes. It's the urgent reason why a Marriage and Parenthood Reset work group is currently, right now, reviewing how to make family formation more achievable. And as part of that agenda, they're comprehensively reviewing support for egg freezing, fertility tests, and all sorts of fertility treatments to help citizens build their family. And this brings us right to the core thesis of what we're talking about today. Look, expanding financial support for fertility treatment is, on the surface, a wonderful initiative. We all know fertility treatments are financially and emotionally exhausting. But here is the critical caveat. Increased funding and wider access without strict medical guardrails, well, it might just end up subsidizing anxiety rather than actual parenthood. Because without access to clear, independent information, public money that's intended to help people become parents might just end up funding unnecessary, unproven medical procedures that offer very little, if any, proven benefit.
Section 2. Selling certainty and control.
So how exactly does this happen? Well, to understand that, we need to zoom in from the macro policy level right down into the micro level, the clinic room itself. We really have to look at why patients are uniquely vulnerable to the fertility industry's sales pitch, especially when you're in a hyper-competitive society where the fears of disability or just falling behind are incredibly high. Let's look at one specific demographic pressure point. Researchers call it the mating gap. Back in 2021, 64% of Singaporean women aged 25 to 34 held university degrees. Compare that to 56% of men. Now, this disparity makes finding an equal partner increasingly difficult. For single women who deeply, deeply want children but just haven't found the right partner, they feel this immense squeeze. And because single women in Singapore cannot use donor insemination, elective egg freezing often feels like literally the only way to keep their reproductive options open. They're making a deeply fraught decision under immense societal pressure. Now, for couples actively undergoing IVF, the pressure is a bit different, but it is equally intense. They might be terrified about their age, or maybe they have a heartbreaking history of miscarriage, or they're just terrified of having a child with a medical condition like Down syndrome. And this fear, it makes it very easy for clinics to sell certainty. Enter PGTA, or pre-implantation genetic testing for aneuploidy. Essentially, this is a test that checks embryos for genetic abnormalities. So if you're a patient deeply fearful of a genetically abnormal fetus, or maybe you have a strong religious aversion to abortion, this test is often framed to you as a highly responsible, absolutely necessary safeguard. You basically feel compelled to buy this peace of mind.
But here is the massive, often entirely unspoken caveat of PGTA that patients rarely hear in the clinic. Because this test requires extracting a tiny sample of cells from the embryo's outer layer, and keep in mind, that's the part that actually forms the placenta, not the baby itself, that extraction process can potentially damage the embryo. You're actually risking hurting the chances of a successful pregnancy. And furthermore, some embryos have a mix of genetically normal and abnormal cells. These are called mosaic embryos. And the science actually shows that these mosaic embryos can sometimes self-correct into healthy births if they're just left alone.
And unfortunately, the upsells don't just stop at genetic testing. Think about couples who have endured the absolute heartbreak of failed IVF cycles. They are uniquely desperate. They're searching for any possible edge, anything that might work.
And this makes them easy targets for what the industry calls IVF add-ons. We're talking about things like so-called experimental immune infusions, time-lapse imaging, endometrial scratching, and even cleverly named highly marketed products like embryo glue. These extras can feel like the missing magic bullet for a desperate couple, even when they're entirely experimental, totally unproven, or maybe only medically useful for a very tiny, highly specific subset of patients.
Section 3. What the evidence actually says. Now, what's really interesting about this next part is we're going to leave the glossy marketing brochures totally behind and pivot strictly to the data. We need to look at what the actual peer-reviewed medical evidence says about these heavily promoted fertility treatments. Let's start with elective egg freezing. Can it be valuable? Yes, absolutely. But it should never be sold as a guaranteed promise of a future child. Check this out. While planned egg freezing cycles nearly quadrupled recently, the return rates for the 2014 to 2016 cohort are incredibly low. 94.3% did not return to use their eggs within 5 to 7 years. Only 5.7% actually returned to use them. And for women who froze eggs in their early 40s, it was about 8%. The data clearly shows this acts more as an expensive psychological reassurance than a guaranteed, concrete pathway to motherhood.
Okay, let's systematically break down the actual evidence for those IVF add-ons we discussed earlier. Take PGTA. The marketing claim is pretty bold. It prevents abnormalities. But the actual evidence from massive studies, like the STAR trial and a major Chinese study, they show no significant improvement in live birth rates. In fact, an analysis of over 133,000 U.S. IVF cycles linked routine PGTA to a lower overall live birth rate. That's huge. Then there's time-lapse imaging, which is aggressively marketed to select the best embryos. Yet, the landmark 2024 TILT trial published in The Lancet demonstrated conclusively that it does not significantly increase live birth rates. It just doesn't.
And this concern is widespread across the entire industry. There was a sweeping 2026 meta-analysis by the University of Melbourne that looked closely at common IVF add-ons and found some really serious weaknesses in the research backing them up. Get this, out of 10 add-ons they reviewed, 7 showed absolutely no measurable benefit or rested on very low-quality evidence. 7 out of 10. And yet, despite this totally damning scientific consensus, over 70% of IVF patients in Australia, New Zealand, and Britain still use at least one add-on. Why? Simply because it's offered to them by an authority figure in a white coat.
And we must remember, these upsells are not victimless. They carry real, sometimes devastating risks. Australia's Monash IVF recently had to pay a massive settlement of 56 million Australian dollars to about 700 patients. 56 million. Why? Because of faulty embryo screening. This staggering number proves that when these unproven add-ons fail, the financial and emotional toll on hopeful parents is nothing short of catastrophic.
A huge part of this problem lies in clinical risk communication. Clinics will often manipulate how risk is presented to patients. For example, let's say the risk of Down syndrome rises from 0.1% at age 25 up to 5% at age 45. A clinic might quote this as a terrifying 50-fold increase. Now that is relative risk, and honestly, it sounds incredibly scary. But the absolute risk, it's merely a shift of 4.9 percentage points. That's a completely different vibe, right? Patients deserve to hear both figures, not just the one specifically designed to frighten them into spending 20 to 30% more per cycle on extra testing.
Section 4. The next ethical frontier.
As if the current landscape wasn't already complicated enough, we have to look ahead. We're now transitioning into the future of the fertility industry, and we're looking at how this relentless commodification of fertility is pushing us into even more questionable and frankly precarious ethical territory. The next frontier is what's known as polygenic testing. American startups are already out there marketing the whole genome sequencing of embryos. This technology basically promises to generate scores linked to socially desirable traits, theoretically allowing parents to choose their offspring based on the likelihood of things like height, intelligence, or future disease risks. I mean, this brings up monumental ethical questions. Singapore really needs to establish clear, robust limits before commercial services successfully normalize the selection of socially desirable traits as just a routine medical practice.
And this brilliantly illustrates the disconnect between science fiction marketing and actual biological reality. If you sort through the very few embryos produced by a single couple who, by definition, inherently have limited genetic variability, the promised gains are mathematically tiny. We are talking about average differences of only around 2.5 centimeters in height, or a mere 2.5 IQ points. So the promised designer baby is, mathematically speaking, just an illusion.
But the risks of trying to chase that illusion? They are immense. The biological trade-offs of polygenic testing are massive and still super poorly understood by science. Genes do not act in isolation. They almost always affect multiple traits simultaneously. For instance, the very same genes that are linked to a slightly higher IQ may also be associated with increased risks of autism or bipolar disorder. You can't just pick and choose without consequences. Selecting for one trait might unwittingly lock in a severe vulnerability for another.
Section 5. Safeguarding Public Health Funds. So where do we go from here? We are moving to the final constructive resolution phase of this explainer. If the government is going to step in with increased financial support, we desperately need to focus on what actionable, concrete policy safeguards the Ministry of Health should adopt to protect patients. The good news? The solutions are practical and preceded. The Ministry of Health should look to adopt UK-style safeguards. This means implementing a strict, easy-to-understand traffic light rating system for all IVF add-ons. If an extra is rated red, meaning its benefits are not clearly established or it's potentially harmful, it should be banned outright, no questions asked. Furthermore, clinics must be required to provide plain language cost and evidence disclosures, and they must publish independently audited live birth outcomes broken down by age group. Britain's fertility regulator already gave PGTA a red rating. Singapore can certainly step up to protect its patients from similar clinic upselling. So the crucial point is that we must empower the patient journey. And true empowerment doesn't mean offering a confusing menu of unproven treatments. It means offering absolute clarity. This requires 3 things. Step 1, mandatory, unhurried fertility and genetic counseling. Step 2, ensuring patients have dedicated, strictly enforced reflection time before signing any consent forms. They need space to breathe. And Step 3, actively guiding patients toward cheaper, proven, and safer alternatives. For example, instead of risking embryo damage with PGTA, patients can and should be pointed toward non-invasive prenatal testing, or NIPT, and advanced ultrasounds to detect Down syndrome safely once a pregnancy is actually established.
As Singapore moves forward to support families, we absolutely have to recognize that supporting parenthood truly matters. It's vital. But protecting highly vulnerable patients from being sold false hope that modern medicine simply cannot yet deliver, matters just as much. So I'll leave you with this provocative question to consider. As we expand public funding, exactly where is the line between genuinely funding parenthood and inadvertently subsidizing false hope? Thank you so much for joining this explainer. See you next time.